good evening, everyone. Welcome to our 97th Blades Virtual Seminar. Blades Virtual Seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And this platform is sponsored by Tankara Technologies for the Getnet project with Blue Health Ethiopia. Getnet is a comprehensive platform dedicated to offering valuable information on pregnancy, childbirth, and the initial stages of childhood development, catering to both parents and expectant mothers. Additionally, Getnet offers the convenience of doctor consultations for individuals seeking professional advice. Moreover, Getnet features a marketplace that showcases a diverse range of maternity-related products, providing a one-stop solution for the needs of expectant mothers. Getnet has entered into a collaborative partnership with Blue Health Ethiopia, with the primary objective of enhancing the expertise and knowledge of Getnet's medical professionals, primarily focusing on the intricate aspects of pregnancy. So this alliance is geared towards providing specialized training and upskilling opportunities for doctors associated with Getnet, so ensuring that they are well equipped with the latest insights and advancements in the field of obstetrics. So to say a few things about Blue Health. Blue Health Ethiopia is a medical consultancy company founded by medical doctors and a computer engineer. And we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge and preventive medicine. And I'm your host, Dr. Yehenot Adela, a general physician and first aid trainer from Blue Health Ethiopia. Today, it's a pleasure to have Dr. Getnet Alemayew here with us to have a presentation on postpartum hemorrhage. You might remember Dr. Getnet Alemayew from his previous presentation on antepartum hemorrhage, which you will find on our YouTube channel if you have missed it, if you have missed the previous webinar. So for those of you who don't know Dr. Getnet Alemayew, he is an assistant professor of gynecology and obstetrics at Harvard University. He completed his residency in gynecology and obstetrics from St. Paul Hospital, Millennium Medical College.
Thank you very much for your nice introduction and for making these things to happen. I'm really thank you for both Blue Health Ethiopia and Getnet for preparing such kind of presentations and to give an insight for audiences. So today I'm going to present on postpartum hemorrhage. So last time I just started to present the obstetric and emergency cases. So last time I discussed on antepartum hemorrhage. So today I'm going to proceed to the postpartum hemorrhage. So this is my outline. So before I start discuss about postpartum hemorrhage, let me try to discuss about maternal death. So as all of you know, so maternal death is a death of the patient while pregnant or within 42 days of termination of pregnancy, irrespective of the duration and site of pregnancy and from any cause related to or aggravated by pregnancy or its management, but not from accidental or incidental cause. So globally, the maternal mortality ratio is decreasing from the previous years. So currently in 2020, so when we write globally, the maternal mortality ratio is was 223 maternal deaths per 100,000 live births. So this is has significant variation based on the economic status of the country. So in high-income countries, it has an incidence of 12 maternal deaths in 100,000 live births. In low economic countries, so it was 413 per 100,000 live births. So in our country, maternal mortality ratio was 401 per 100,000 live births in 2017. So the cause for such maternal deaths are hemorrhage, obstructed labor, or rupture of uterus, pregnancy-induced hypertension and sepsis in the ancestral portion was the top 5 cause of maternal deaths in Ethiopia between 1990 to 2016. But currently, in recent years, so the causes are changed. So currently, the top cause of maternal deaths is hemorrhage, which is followed by pregnancy-induced hypertension and sepsis. So this is worldwide data. So it's these are the 5 causes of maternal death. So as you see, obstetric hemorrhage which accounts for 27% of maternal deaths, both in developed and developing countries. So I'm going to discuss on such topic. So it's one of the leading cause of maternal death. So this obstetric hemorrhage can be antepartum or postpartum hemorrhage. So last time I discussed on the antepartum hemorrhage. So today I'm going to present on the postpartum hemorrhage. So as I said before, it is one of the top cause of maternal mortality. It accounts for 25% in an incidence of 4 to 5% incidence. So coming to the definition of the postpartum hemorrhage, so there is different definition from different guidelines and literature or standard textbooks. But ACOG define postpartum hemorrhage as a cumulative blood loss greater than or equal to 1,000 ml or blood loss which is accompanied by symptoms of shock within 24 hours of delivery, regardless of the mode of delivery. But traditionally, we defined postpartum hemorrhage based on the estimated blood loss, the hematocrit level, vital signs, derangement, and need for transfusion. So we said PPH when there is more than 500 ml vaginal delivery, more than 500 ml blood loss after vaginal delivery, and more than 1,000 ml blood loss after cesarean delivery, or if there is decrement in the hematocrit level, more than 10%, and if there is vital signs, derangement, or need for transfusion, we can diagnose postpartum hemorrhage in our setup. So it can be minor postpartum hemorrhage or a major postpartum hemorrhage. So minor means when the estimated blood loss is between 500 to 100 ml, and if it is more than 1,000 ml, we call it a major postpartum hemorrhage. The other time is massive PPH, which is defined as loss of, if there is estimated blood loss of greater than 2,000 ml, or if there is hemodynamic instability, or if there is signs of shock as a result of obstetric hemorrhage of any amount over 500 ml. We call it massive hemorrhage, massive PPH or hemorrhage. In addition to that, we can also say massive hemorrhage when the amount of transfusion is more than 4 units. It's being transfused, and the further units are required regardless of the amount of blood loss. We call it postpartum massive PPH. So it can be classified as a primary PPH or secondary PPH. So the primary PPH, so the PPH occurs within 24 hours of delivery, and say primary PPH. But if it is after 24 hours of delivery, up to 6 to 12 weeks after delivery, we say secondary PPH or deep PPH. So how do we estimate blood loss? So here's different ways of quantifying the amount of loss. But usually the visual estimates that were doing low setup. So visual estimate, which is very inaccurate to estimate the exact amount of loss because of its tendency to underestimate the loss of surgical loss of blood, and which there is some clinical science which is associated with specific amount of loss, which is really even reliable than the amount of visual estimation. So we can estimate the amount of loss based on this hemorrhage classification and the physiologic response. So as I said before, as I said in the last presentation, so there is class 1, class 2, class 3, and class 4 hemorrhage classes. So based on the amount of loss, each class has its own response, physiologic response. So based on that, we can estimate the amount of blood loss. So this clinical science is more reliable than the visual estimation. But there is also other ways to estimate. So if it is a 10 by 10 centimeter goes, if it is soaked 100%, so we can estimate it as 12 milliliters of blood. If 13 by 30 centimeter goes, it's soaked 100%, so this amount is comparable to 100 ml. And if it is 45 by 45 centimeter pack, so we can estimate as 116 ml of loss. So this is a visual estimation. So as I said before, the definition of PPH is different. So even we couldn't estimate the exact amount of loss. So because of that, different guidelines states different amount of loss for each definition. And there is no universal accepted definition, and even the less amount of blood can lead to complications. And generally, there is no single satisfactory definition for PPH, but the one we mentioned before is acceptable ones. And the etiologies for postpartum hemorrhage, there is a primary and secondary causes. So for primary postpartum hemorrhage, you try not only genital tract laceration, retained products of conception, coagulopathies are the mentioned causes for primary or early PPH, and for secondary PPH or late PPH, which occur after 12 hours, after 12 or 24 hours of delivery, is infection, retained product of conception, placental sites, embolization, coagulopathies, and choriocarcinomas are the aforementioned cause for PPH. So from those primary PPHs, we try not to account for 18% of PPH. So I'm going to discuss on detail on uterine anatomy. So how we define uterine anatomy is inability of the uterine myometrium to contract effectively after delivery. So normally after delivery, the uterus should be contracted well, and even one of the mechanisms for controlling blood after delivery from the placental site is because of the contraction of the myometrium. So the inability of the uterine myometrium to contract effectively will cause massive hemorrhage, and it's called uterine anatomy. So there are risk factors for uterine anatomy, like uterine overgestation, labor induction. So those mothers who have prolonged or rapid onset of labor, big grand multiparity, presence of uterine infection. If there is uterine inversion, there is also retained product of conception, abnormal placentation, and use of uterine relaxing agents like tocolytics are risk factor for uterine anatomy. So patients who have uterine anatomy is diagnosed clinically if there is a rapid uterine bleeding, which is associated with lack of myometrial tone or broken uterus in the absence of other etiologies. We can diagnose uterine anatomy. So typically, the manual palpation of the uterus will confirm our diagnosis. If the uterus appears to be firmly contracted or is contracted well, so other etiologies should be considered. So this is the second common cause for PPH is genital tract trauma. So such trauma is related to uterine rupture or can be from genital tract laceration like penile, vaginal, cervical uterine laceration, or it can be from genital tract hematomas like labial or vaginal ligament or retroperitoneal hematomas can occur after delivery. So the diagnosis is suspected when there is bright red or bleeding in the presence of contracted uterus. So our top differential should be genital tract trauma. So adequate exposure and evaluation is needed to check for presence of genital tract trauma. So is the risk factor for trauma? So risk factor for risk factors, which is mentioned for vaginal deliveries, like in use of instrumental deliveries, midline episiotomy, fetal malpresentation, presence of macrosomia, precipitous delivery, sugar distortion, as are mentioned risk factor for genital trauma after vaginal delivery. And if it is cesarean delivery, there is also risk of uterine extension. So usually these things occur if the surgery is done after the station is engaged, or if the station is low, or if it is done after application of instruments or extension from the incision site, or might be occur. The third cause for early PPH is presence of retained placental tissue. So failure to deliver the placenta in the membrane fully or partially following active management of labor is called retained placenta. Usually it is diagnosed if the placenta is not delivered after 30 minutes of delivery of the last baby, and it accounts for 5 to 10% of PPH. So these are the risk factors for retained placenta, like presence of infection, constriction of the cervix or lower uterine segment, or the deliveries in the mid-times, the delivery, there is mismanagement of certain stage of labor and non-timings of epidemiology, as a mentioned risk factor for retained placenta. So the first cause of PPH in early can be also even in the late PPH is coagulation failure or coagulopathy. So any management on hemostasis results in excessive bleeding, and this kind of problem will complicate around 1 in 500 persons, and is responsible for up to 7% of cause of PPH. So it can be acquired or congenital one. These are the acquired and the congenital cause of coagulopathies. So usually coagulopathy is suspected if you ruled out those mentioned causes, or if there is a presence of risk factor for coagulopathies, like presence of fetal demise, DIC, if the patient has HELLP syndrome, thrombocytopenia, or presence of placental abruption, sepsis. There is severe hemorrhage, which is due to consumptive coagulopathies, or presence of fluid embolism as the mentioned risk factor for coagulopathies. So those mothers who have such problems will be at risk for coagulopathies. So usually we diagnose such things by assessing the risk factors, both antepartum or intrapartum, or by performing bedside coagulation test or doing coagulation profile. Usually diagnose coagulopathies. And also, if you found bleeding from other sites, can be also additional evidence for coagulopathies. Okay, so how to prevent postpartum hemorrhage? So by preventing or treatment of anemia, or by attendance is skilled one. So by skilled delivery by skilled person, or by active management of third stage of labor, we can prevent postpartum hemorrhage. So there are some risk factors are mentioned for assessing the risk of postpartum hemorrhage, but even in the absence of such risk factors, we will get postpartum hemorrhage. So there is no assessment. So there is no strong indicative assessment method for estimating the likelihood of PPH. So generally we can prevent it by applying active management of third stage of labor, which includes administration of etiologic drugs after the delivery of the fetus, and applying control cord traction, and by doing uterine massage, you can prevent PPH. So before proceeding to the management, so let me mention something. So the key to management for PPH is to recognize excessive bleeding before it becomes a life-threatening one. So identifying the cause and initiating the appropriate intervention based on the clinical setting is important. The other thing, if you initiate management, so we will start with non-operative ways of management and we will proceed to operative intervention. So one of if it's non-operative treatment sequence. So unnecessary delay in the appropriate intervention will result in excessive hemorrhage, which increase the likelihood of hysterectomy, major morbidity from hemorrhagic shock or death might happen. So when the intervention is failed, the next treatment modality should be applied. So the goal for the management of PPH is to restore or maintain adequate circulatory volume and to restore and maintain adequate tissue oxygenation and prevent or reverse the dilution of coagulopathy and elimination of obstetric cause of PPH is our goal. So this is a general management of postpartum hemorrhage. So once you identify PPH, you should call colleagues. So you shouldn't manage by yourself. So if you need to involve or call other personnel, so the first thing that you are going to do is shout for help, and you will establish a large bore IV lines bilaterally, and you will take blood sample for CBC, coagulation profile, for renal liver function test, and you will send blood group average and cause much blood. So after doing that, you will initiate resuscitation and monitoring. So you will start resuscitation with crystal rates, and you will consider if there is an indication for transfusion, you will consider blood transfusion and position the patient flat and give oxygen and catheterize to follow urine output and monitor the vital signs, even the trend of the vital sign over time, and the blood should be quantified. And you can apply NASG. So if this thing is not done in the operating room and the patient is unstable, so it's better to take the patient to the operating room for better management. So after doing that, we will need to determine the cause of bleeding. So we rapidly assess the uterine tone, the genital tract should be examined for laceration, the uterine cavity should be examined for retained placental tissue or defects, and the test should be assessed for uterine inversion. And if the patient has intense pain in the perineal region, is a warning sign for vulvar or vaginal hemodoma, because such patients doesn't have a visible vaginal bleeding. So the patient has severe pain, which is not proportional to the amount of vaginal bleeding. The one thing that we should consider is hematomas, vulvar or vaginal hematoma, and the presence of compensated or uncompensated shock without vaginal bleeding also need further evaluation and further consideration for internal bleeding. So such patients should be operated, and the coagulation status of the patient, the drugs that she received should be also reviewed. So how do we resuscitate? So we initially resuscitate them with crystalloids. So crystalloids are the first line for resuscitation. So our target for resuscitation is to keep the fetal blood pressure greater than 90 mmHg and to maintain the urine output more than 30 ml per hour. And rapid infusion of crystals like more than 3 to 4 liters may promote dilutional coagulopathies like electrolyte imbalance and hypothermia. So appropriate monitoring of the hematocrit coagulation status, the temperature and electrolyte is essential, and the ratio of resuscitation, that's the ratio of fluid to blood. The blood is 3 to 1. So for each 3 liters of crystal administration, for each 1 liter of blood loss, we need to administer or resuscitate them with 3 liters of crystals. So the 3 to 1 ratio is important. Otherwise, if it is more than that, so the patient might be at risk for dilutional coagulopathies of the patient who might develop electrolyte imbalance. So if she needs replacement for blood product, it is important to replace with blood rather than to give crystalloid infusion or a massive hemorrhage. So the transfusion, initially we initiate or start to transfuse them with twins of packed RBC. For patients who have also dilutional coagulopathies, aggressive replacement of plasma should be applied, and those mothers who have massive hemorrhage, so the massive transfusion protocol should be initiated. So the one-to-one approach is applied. So one packed RBC, one fresh plasma, one platelet should be given for the patient. So our target is to make the hemoglobin level greater than 8, the platelet count to make it greater than 15,000, and the fibrogen level should be greater than 300, and the prothrombin time is less than 1.5 times of the control value is our target transfusion. After doing that, we are going to provide specific treatment for specific cause of hemorrhage. So if it is uterine atony, we will manage atony. If it is laceration, we will replace the laceration. If it is a causes retained placental tissue, so we will remove the causes inverted or uterine inversion that should be replaced manually. Or if it is due to uterine rupture, it should be managed accordingly. So after doing such general management, we should go to specific management for specific cause of PPH. So if you diagnose uterine atony as a cause of PPH, then the recommended intervention is one is uterine massage by manual compression, ultrasonic drugs. These are the recommended intervention, the recommended initial intervention for patients with uterine atony. This is how you are performing bimanual uterine compression. So the clinicians with two hands, one in the vaginal canal and one on the abdomen, will compress the uterus in between. So such changes should be maintained while other interventions are being initiated and continued until the uterus remains contracted and the bleeding is stopped. So while doing this procedure, we should to avoid aggressive massaging, which can cause or injure the large vessels of the broad ligament. So gentle massage or compression, bimanual compression is important. So one is doing or performing uterine massage and compression, and the other is applying or doing aortic compression. So it will use density temporary measures. So until appropriate care is given for the patient. So as we see here, so the patient's one hand is on the pulse. So if you will assess the femoral pulse and apply compression on the aorta, which is found just above the umbilicus and to the left, just above and to the left of the umbilicus. So we'll apply pressure. So to stay effective, when you apply the compression, the femoral pulse should be absent. So if it is absent, so your aortic compression is successful. So the mainstay of drug therapy for which anatomy is nitrotonic agents, and oxytocin is a first line agent. So it is the drug of choice, and it can be administered intravenous, intramuscular, or intrauterine, intramyometrial. So the IV one is best. So if we are giving oxytocin with maximum dose, if it is failed to produce adequate uterine tone, we need to proceed to the second line therapy. So these are the nitrotonic therapies. So can give oxytocin up to 18 international units in 500 to 1000 ml of crystalline solutions. But the side effect is like nausea, emesis, hypotension, water intoxication might be found. So the other nitrotonic agents like misoprostol, ergometrin, like prostaglandin E3, dinoprost. So these are the options of nitrotonic agents. So how do we decide about only using the nitrotonic drugs? So it's depends on the availability of the drugs. So if you found or if you are accessible with oxytocin, you will start with oxytocin. But if it is not available, or if it is not, if its quality is not guaranteed, you can use carbidocin, like heat stable carbidocin, like ergometrin, or you can use misoprostol. So if you couldn't find oxytocin at hand, you can use such options of nitrotonic drugs. The other medication that you are going to give is tranexamic acid. This is an IV antifibrotic drug, which is important for prevention and treatment of hemorrhage in a variety of clinical settings. So its use is extrapolated from trauma patients, and it has a 20% reduction in the maternal death and a 30% reduction on the need of laparotomy. So tranexamic acid even can be administered or as a one component of active management of such stage of labor, regardless of the cause of bleeding. So when you are going to give tranexamic acid, it should be given within 30 minutes. Otherwise, every 15 minutes, the efficacy of the drug is decreased by 10%. So to avoid that, it is better to provide it within 3 hours of delivery. So to give, you give them 1 gram IV, a slow push over 10 minutes, and depending on the bleeding, you may add or give a second dose after 30 minutes, or if the bleeding restarts within 24 hours of completing the first dose. The other advantage of tranexamic acid is cheap, easy to administer, and even usually available in healthcare settings, in the primary healthcare centers. And it has a shelf life of 3 years, and it can be stored in room temperature. Then the contraindication for tranexamic acid is presence of intravascular. If there is active intravascular clotting like DIC, or if there is hypersensitivity to TXA, so the contraindication. So if it is accessible, it's best to give it to the patient. So if those mentioned pharmacological methods, if not controlled, we should proceed to the other alternative measures. So before proceeding with this measure, The genital tract should be carefully inspected for laceration. Once laceration has been excluded, other intervention can be undertaken. So, one is uterine tamponade. The other is selective arterial embolization or surgical intervention. So, these are the interventions that you are going to do if the pharmacological methods are failed. So there are different techniques for there are different methods or tamponade techniques. So it's mainly provide or prevent bleeding by act as a tamponade to the bleeding uterine surface. So there are different types of balloon catheters which we are going to use for uterine tamponade, ranging from devices which is specifically designed for uterine tamponade and those designed for other indication and can be used as a tamponade if it is not available to use normally marketed intrauterine tamponades. So the commonly used ones are bakery balloon tamponade. In those, as like in our setup, we can use also Foley catheter. So you can insert one or more 16 ml of 16 ml Foley catheter is inserted in the uterus and you will fill with 16 ml of normal saline. Or you can use also condom catheter. So you can use condom catheter or a Foley catheter to act as a tamponade. So the picture shows condom catheter. So the condom is normally placed over the end of the Foley catheter and the base of the condom is ligated to the catheter to prevent backflow. Then the condom is filled with 500 ml of fluid or normal saline. Then you will keep it there in the uterus. This is the normal so this is a normally designed uterine tamponade, which is called bakery balloon tamponade. The other way of other intervention is selective arterial embolization. Here, diagnostic pelvic angiography used to visualize a bleeding vessel. Then you will apply Getnet base into the vessel and will occlude the bleeding vessel. So this procedure can be done alone with other failed surgical or after failed surgical intervention. So the candidates for selective arterial embolizations are women with persistent slow but excessive bleeding or hemodynamically stable and have failed less invasive therapies. And the success rate of selective arterial embolization is up to 19 to 97%. So the other intervention is surgical intervention. So when the uterine atone is not responsive to conservative management, so surgical interventions by laparotomy is necessary. So after doing laparotomy, this intervention can be done. One is arterial ligation. So the blood vessels which is supplied the uterus will be ligated. The other is applying uterine compression sutures. The third one is, or the definitive one is, doing hysterectomy. So what is the goal of arterial ligation? Is just to decrease the uterine perfusion and subsequent bleeding, or can be done while doing other definitive treatment. So the success rate of arterial ligation is range from 14 to 95% based on which vessels are ligated. So there are different arteries that are going to be ligated. One is ascending or uterine arteries. Then intra-ovarian arteries, IP ligament vessels, internal iliac or hypogastric arteries can be ligated. So while doing this, we follow the stepwise progression of uterine basal ligation is recommended. So you start with ascending uterine artery. Well, if you start with uterine artery ligation, you can do in one side or both sides. Then if the bleeding is persisted, you can do intra-ovarian artery ligation. Then if it's failed, proceed to the other arterial ligation. So this picture shows uterine artery ligation techniques. So as we see, the uterine artery is ligated around the uterine incision site. The intra-ovarian artery is also ligated there. Even we can do or insert tamponade while the arteries are ligated. So both, if you apply both techniques, it is called bilateral looped uterine basal suture, which means you will ligate the basal and you can also insert the uterine tamponade. The third intervention is uterine compression sutures. So there are different techniques to apply compression suture. So the mechanism of action of this technique is by promote mechanical compression as well as a reduction of blood flow in the uterine artery while when you apply compression. So it has a success rate of more than 18%, and it can be also combined with tamponade balloons for refractory bleeding. So these are the techniques, commonly used techniques is bleeding, which is one is a modified bleeding or the hymenal, the hymen vertical suture. Or you can use other techniques like pera, transverse or vertical suture, or multiple square sutures can be applied. So when you apply such sutures or compression sutures, so you mechanically compress uterus and uterus and uterine arteries. So it will reduce the amount of blood to the, or the amount of bleeding from the uterus. So after doing this, so first you initiate a conservative medical management, like you massage the uterus, you apply the uterotonic, you give uterotonic drugs, you do conservative surgical techniques like insertion of intrauterine tamponade, doing compression sutures. After all such measures, if the bleeding is persisted, so our last option is doing hysterectomy. So hysterectomy, the removal of the uterus, is a definitive management for PPH. So the other cause of PPH is treatment. The other cause of PPH is genital trauma. So if you diagnose genital trauma, you will treat. So to do that, there should be adequate exposure to repair the laceration. So if the laceration is extending to the uterus, or if the apex of the laceration is not visualized, so laparotomy is important. Or if the hematoma is more than the vulvar or vaginal hematoma, if it is more than 5 centimeters, or if it is increasing in size, it should be evacuated. If the bleeding continues while the uterus is contracted and while you are ruled out genital tract laceration, so the patient clotting status should be assessed for coagulopathy. Here I also give TXA or tranexamic acid. The third cause of PPH is retained placenta. So if you diagnose retained placenta, you will initially give 10 units of oxytocin, then you will check the tone of the uterus and attempt control contraction. And after doing that, if the placenta is not delivered, you will perform manual removal of the placenta. While you do this, the patient should be catheterized because one of the common cause for retained placenta is gallbladder. So after doing this, if the placenta is still not removed or delivered by manual removal, we should consider other pathological adherence of the placenta or morbid adherence of the placenta should be considered. Or if the cause of retained placenta is due to constriction ring or due to difficulty in passing our hands through the cervix or the lower uterine segment, we can also extract the placenta by using open forceps or wide curate in the operation theater. But if the remaining tissue is a fragment of placental tissue, we can remove such placental fragments by hand or open forceps or wide curate. So one thing that you should be cautious is very adherent tissue might be more lipidally adherent placenta. So if it is, you are thinking that it is very adherent to the uterus, you should consider morbid adherent placenta. If you apply extra effort to remove the fragment, the patient the patient might goes to develop severe bleeding or the uterine perforation might be occur. So such things should be considered. So for patients with secondary PPH, so in women presented with secondary PPH, so ultrasound assessment for retained products of placental tissue and the appropriate use of antimicrobial therapy should be initiated in endometriosis is suspected. If the uterus is atonic, as we said before, give them microtonic agents or surgical procedures can be done for retained placental tissue. After arresting PPH, what we are going to do is we follow the maternal vital sign every 15 minutes, and urine output for at least, and also urine output also should be followed for at least 2 hours, and monitor the bleeding vital signs for next 6 hours. And the tone of the uterus should be assessed every 15 minutes for the next 2 hours. Continue IV fluid oxytocin drip for next 2 hours. Continue blood transfusion if it's indicated or initiated. If the patient is stabilized, then assist her to initiate breastfeeding. One thing that I'm going to mention is the use of non-pneumatic anti-shock garment or mask. So this is the material mask. So this is the steps to apply mask. So mask when apply means applying. You apply pressure to when you apply a mask. You will apply pressure on the lower body or abdomen, thereby stabilize the vital signs and resolve hypovolemic shock. So when you apply on the lower part of the body, so the amount of the blood loss will be decreased. One thing, the other is the normal flow will be reserved. Flow will be reserved for other critical organs. So mask can be used as a temporizing measure. So it's not a definitive one. It's one of the temporizing measures, like that's we're applying like aortic compression or bimanual compression. So it's also one of the temporizing measures until appropriate care is given for the patient, so it can be applied. So when you apply mask, so you shunt the blood from the veins of the abdomen and lower extremities to the vital organs like heart, lung, and brain. So it's applied for up to 48 hours. So the indication for NASG, if the patient had shock due to postpartum hemorrhage or trauma with injury or hemorrhage below the diaphragm, or if the patient has hemorrhage, we apply NASG, and the contraindication for NASG is the presence of viable fetus in the utero, pulmonary edema, being above the diaphragm, presence of CHF, the risk for its contraindication for applying NASG. So NASG normally will be removed when the patient is stable for at least 2 hours. In the intravascular volume, re-expanded with blood and saline, and the vital signs should be stable, and specifically the systolic blood pressure should be greater than 100 millimeter mercury, and the pulse should be less than 100, and the hemoglobin level should be more than 7 or out of it more than 20. We can remove NASG. But make sure when you are removing the NASG, you should take the vital signs every 15 minutes, and you will start to remove the NASG starting from the lower value, like from the lower extremity. Like 1, you will start to remove the number 1, the number 2 segment, number 3 segment, and the pelvic and abdominal segment should be removed subsequently. But while you are removing the NASG, you should take the vital sign every 15 minutes. So this is a basic PPH kit that every facility should be prepared. So it will include the oxytocin, it will include oxytocin, misoprostol, gometrin, polycatheter, fluid, cannula, different sizes of syringe, gloves, and uterine balloon tamponade should be there to prepare a basic PPH kit. So it should be prepared every setup, and it can be also it is easily as accessible as even in the health center. So it's better to prepare such kits. So we generally discussed that one mentioned before. So this is a flow chart for PPH treatment, especially in the hospital level. So if you diagnose PPH, the first thing that you should do is shout for help, evaluate for ABC of life, assess the airway, breathing, circulation, secure IV lines, and start resuscitation, give oxygen, determine the hematocrit level, assess the coagulation status, and prepare blood product, catheterize the patient, follow urine output and vital sign. After doing this, if there is oozing from the vein puncture site, or if there is thrombus that would be in your abdominal coagulation test, manage for coagulopathy. If there is any signs of coagulopathy, you will assess the placenta. So, is the placenta delivered or not? Is the first thing that you are going to ask. So, if the placenta is delivered and it is complete, then the next step is diagnose, assess the uterus, and apply fundal massage. Give uterotomic drugs like oxytocin, administer tranexamic acid, and reassess the uterus. If the uterus is contracted and no bleeding, continue oxytocin. If the uterus is contracted but still there is bleeding, explore for genital tract trauma. So, if there is no lower genital trauma, explore the uterus. If the trauma is on the cervix, or if it's extended to the upper or the extended to the uterus, do laparotomy. If it is easily accessible, repair. Or if the uterine is diagnosed, follow the steps of management of uterine anatomy, like fundal massage, additional administration of uterotonic drugs, balloon tamponade, conservative surgical managements like compression application of compression sutures and arterial ligation. And finally, if it's not responsive, do hysterectomy. those patients who have delivered their the placenta and it's complete. But if the placenta is not delivered or complete, manually explore the uterus. And while doing the exploration manually, if there is distinct cleavage, remove the placenta manually. But if there is indistinct cleavage or if there is adherence with the uterine cavity, manage surgically with consideration of morbidly adherent placenta. So if the placenta fragment is retained, you can remove using a curate. If you diagnosed uterine rupture, repair or do hysterectomy. If the cause is inversion, do or replace the uterus with analgesia. If nothing is found but there is bleeding, do conservative surgical management. It's the same flow. So determine establish IV access, blood, or establish IV access, start resuscitation or transfusion. Then determine the etiology, coagulopathy, prepare blood product and start transfusion with massive transfusion protocol. If the etiology is uterine atony, we proceed with the atony management. If the cause of PPH is genital tract laceration or retained product of conception, or is morbidly adherent placenta, or is uterine rupture, or is uterine inversion, manage using operative intervention. So the complication for PPH, like as I said before, one of the top cause of maternal death. So one of the complications is maternal death. There is hemorrhagic shock, organ failure, Shannon syndrome, Asherman syndrome, infection, transfusion-related complication, and other things. They are at risk for recurrence. So those mothers who have single episode of PPH, they are at risk for up to 18% of recurrence, and those mothers who have more than two history of PPH, they are at risk for more than 27% of PPH. So thank you for.
Okay, thank you very much, Dr. Getnet. Yeah, we can proceed to the question and answer section. So if you can access the chat box.
Yeah, sorry, what is NASG? So already mentioned the pneumatic shock garment. So it's one of the temporizing measures for patients who are bleeding. So you can apply as a temporizing measure. So it's already mentioned. Do we have actually used tranexamic acid in Ethiopia? Definitely. Even it's available in the primary hospital. So it can be stored with normal room temperature and can be used even for 3 years. And it's easy to administration. So it's cheap one. So it's available in Ethiopia. Yeah. So does the uterus retain its viability after such ligation? Yes, because of its collateral blood supply from other side. So, but if you apply uterine arterial ligation, so you will follow the stepwise approach. So when you start with uterine arterial ligation. Can be unilateral or bilateral uterine ligation. So if it's failed, you will proceed with retroviral artery ligation. So the uterine blood supply, since it is not only from the single artery, so when you like it, so the uterus can be conserved, but the patient might be at risk for Asherman syndrome. So generally, but if you apply especially if you apply all techniques, viability of the uterus might be in danger. But doing one or two stepwise approach for controlled bleeding doesn't affect the viability of the uterus. Given the risk of DIC, can have a patient with abruption placenta. Okay, given the risk of DIC, can we give to a patient with placenta?
So,
okay, it's a tranexamic acid, sorry. So tranexamic acid, yeah, it can be provided for patients with abruption placenta, unless the patient has DIC. So unless there is DIC, unless if you didn't diagnose DIC, we can give for patients with abruption placenta. Is informed consent required before performing hysterectomy? Definitely. Do we give tranexamic acid and oxytocin simultaneously? Exactly. So even with other protonic drugs. So tranexamic is easily, as I said, it is easy to administer, easy to give with additional protonic drugs, and easy is also has a high success rate even provided along with other ways of management for PPH. So we can give TXA with oxytocin simultaneously. Can we elaborate on massive transfusion? Yes, massive transfusion. So to define massive transfusion, so we define massive transfusion if you transfuse a patient with more than 10 units of whole blood or packed RBC over 24 hours, or if you transfuse a patient with 4 units of blood product within 1 hour, or if you provide if you give blood transfusion like 4 units of blood product over 30 minutes, we can diagnose massive transfusion. So the ratio of transfusion for each product of blood is like 1 to 1, 1, 1, 1 approach. So if you provide 1 units of factor RBC, we will give 1 unit of platelet and 1 unit of FFP. So this is the ratio for massive transfusion, and has its own risks and benefits. So we can read more. The mortality rates after PPH in Ethiopia. So as I said, it is around 27%. So in a patient with abruption placenta in current pregnancy, after delivery after delivery she develops PPH. Is a patient candidate for TXA? A tranexamic acid gives the chance of DIC. As the mechanism of action is somewhat similar. As I said before, unless the patient has signs of active DIC, yes, you can provide TXA for patients with abruption. Even if DIC, one of the complications that we are faced on patients with abruption placenta, unless she had develops over DIC, unless she developed DIC, there is no contraindication. Is there any benefit to give TXA after 3 hours? No benefit. Even if you provide TXA within 3 hours, the effectiveness decreased by 10% for each 15 minutes. So if you delay administration of TXA, so the efficacy will decrease by 10% every 15 minutes. Okay, are mothers informed about the chance of having hysterectomy on the initial consent form, or are we going to ask for hysterectomy consent from surrogate like husband in case of his delivery? Yeah, any procedure, when you are doing any procedure, the risk, the complications associated with the surgery should be advised or told to the patient. So each risk should be told for the patient, and we should have a consent from the family or the mother or the surrogate. Okay, in areas where NASG not available, is there any other equipment or technique that can be used as a substitute? Yeah, as I said before, we can just there is no NASG, so the other conservative measures like doing bimanual compression, doing uterine massage, or doing you can also insert tampons, like as I said before, condom catheter or Foley catheter can be inserted.
Yeah, you addressed all of the questions raised in the chat box. So, yeah. So, on behalf of Ethiopia and all our participants, as well as Latinat, I would love to thank you for taking the virtual seminar on PPH. You have also presented on previously on antepartum hemorrhage. So participants, if you have missed previous presentation by Dr. Getnet on antepartum hemorrhage, you will find it on our YouTube channel. So Dr. Getnet, again, thank you very much for giving us such an amazing presentation on postpartum hemorrhage. So if you have any last remarks that you want to address, let me give you that. Yeah, Dr. Getnet, if you have any last remarks that you want to give up, let me give you the chance.
Okay, thank you all for your really active participation, and thank you all for your patience and active involvement on the topics. And thank you, Blue Hills and Nat, for your invitation and preparation for preparing such kind of presentation. And as a remark, as I said before, PPH is one of the top cause of maternal deaths. So we should know the basics for management of PPH. And thank you all.